the prolotherapy versus the PRP versus the dry needling, tendon needling, and then obviously we have stem cells beyond that. But can you explain the differences between those modalities and I guess from a price standpoint and invasiveness standpoint and potentially even an efficacy standpoint, and when you're dealing with tendons or ligaments as far as the tissue sort?
That's an amazing question. And I've been waiting to answer this for months. So thank you so much for giving me that question. And so, first of all, I'm a chiropractic doctor and I'm not a regenerative medicine doctor, but working with it closely, I think that I have a pretty good opinion on it. And so I'll start first with the regenerative things that I do not offer. Uses dextrose, which is a sugar. And my understanding is that when it's injected into an area, it kind of kills off the first layer of cells, and that stimulates a regenerative healing effect. That the body starts to go in and repair, and hopefully builds back a stronger connective tissue in that area. Which I've seen it work, many times, and it does a very good job when it's the right therapy, when it's indicated. PRP takes your own blood and it tries to make it really rich in the platelets, which are a big part of stimulating repair. And so I'll quickly dive over to the one that I do. So tendon dry needling, when done correctly, also causes blood to go to the area, which is going to have platelets in it. So it's going to give a effect of, a similar avenue of using blood to create healing. And, depending on when you get into, you would have to ask a regenerative medicine specialist, but there's all sorts of variables when it comes to these. And people have, say, well, my PRP is better because, and my PRP is better. So there's a lot of little ways that you can optimize, how effective that it is. But I've also gotten PRP done, and I actually preferred it over the prolotherapy a little bit. I felt like it gave me a little bit better response just personally, but
Were
they
the
both
same
did.
were the same areas being addressed with the Prolo as
Yes,
well as, yeah, okay.
the same areas. And then some doctors will choose Prolo or PRP depending on the region. I think, of course, if you're treating like a meniscus or something like that, I think they usually go more towards PRP or using blood, and you wouldn't want to inject sugar or dextrose, I don't think, into that area.
Right.
Um, but then the strongest regenerative agent known to man is right inside of our own body, and it's bone marrow. So some pretty skilled practitioners will actually pull bone marrow out of your leg or your hip, and then spin it correctly, and then re-inject it into tissue to bring a really profound regenerative cascade.
So the stem cells are one person's their own stem cells, yes?
So that, in from what I've learned, that would be the best way to do it. I mean, it's already your own body's healing ability, and then you're using that specifically to create more healing. There's a lot of other people that use, umbilical cord stem cells, or even stem cells, that are derived or made in different ways. I think a couple of things that are the gray area that some doctors, at some of the clinics that I've studied from, don't prefer is
Yeah.
you don't know how many of them are alive by the time it gets there. Um, there's a lot of variables you can't control, and then it's from a foreign tissue. So, but some people get good results with using those as well.
Now, and also I've noted that especially in my neck of the woods here, there's not a lot of options for practitioners who are willing to do Prolo or PRP at the C1-2 level. Can you address that from a standpoint of safety concern, experience concern? Because obviously the vertebral arteries are quite exposed there at the facets of C1, C2. But what is your experience in the sort of the likelihood of easily finding somebody who would address that area from a regenerative medicine standpoint?
It's a great question. So, just to finish up real quick, because there was one part I didn't ask.
Okay.
Typically, nationwide, I would say an average for getting prolotherapy to the neck would be anywhere from $800 without doing C1, C2, probably up to $2,000 for including the upper neck C1, C2. If you do PRP, I think that treatment ranges more from, this is just my opinion based on what I know, probably more from average of $1,200 without the upper neck up to maybe $5,000 or $6,000 if you also get PRP with the upper neck.
Mhm.
Bone marrow treatments I've seen range anywhere from probably 3 to 4,000 upwards of 12,500 for one round or session of treatment. And then the tendon dry needling is usually anywhere between $200 to $500 per treatment. So that was one part that you asked me to just
Yes,
highlight or
thank
talk
you.
a little bit about. And then efficacy or things like that, it can vary greatly as far as where are you going to get the most bang for your buck or the most value. Because after all, we all are interested to first start with least invasive to most invasive, and then to be mindful of our spend. And if we can get the same result, I think most of us would be happy to spend less to get that same result.
And this is where the
So
DMX comes in handy because you know exactly where you're going and why.
yes. So precisely why, you and I love to use digital motion X-ray to be as precise as we can in how much instability do you have, because symptoms can vary. I mean, I've had people, and I'm sure you have, that only had a little bit of instability on DMX, but their symptoms were debilitating. I mean, they couldn't barely get off the couch,
Yeah.
and we were able to rehabilitate them back to functioning. And then you have other people that say, "Oh no, doc, I just got some neck pain, and if I look left, I feel kind of faint, but otherwise I'm fine." And we find they have 7 or 8 millimeters, and you're like, whoa, this is potentially going to get worse. We have to give you a real careful plan, and you're probably going to want to get some of these other therapies eventually to help you fully stabilize. So yeah, if you don't look, you don't know. And if you can't see it, you can't treat it correctly. So digital
Right.
motion X-ray has been life-changing for my practice. It's been absolutely amazing. But yeah, it's important to quantify those injuries. It's important to try to start with least invasive to most invasive, and to be mindful of cost when you're considering your approach.
Right.
Um, the next question that you asked me that I was going to jump into, can you just reiterate that one again?
I think it was the concern of going up to C1,
For
C2, because
T-Bolt.
you alluded to the expense change between doing everything below that being X number, and then when you include the upper cervical spine, it triples or quadruples in some cases. And just kind of touch on that because I know it's an area of higher risk and
Hmm.
potentially more efficacy if you can find somebody who's proficient in doing it and skilled and experienced.
Definitely. I think it's really important to address. I mean, if you know that you have C1, C2 instability, you have to address things that connect to C1 and C2. And so I always tell people start with just getting, working with somebody like you, work with an upper cervical chiropractor, try to do some gentle strengthening. If you've already exhausted all of those, which most of the people that come to see us, have already tried all of that, then you've already worked with, one of the tools that you've designed, and, they're getting some results, they're getting relief, but they still want more. They're like, okay, I'm considering, what kind of regenerative injections am I going to do to supplement this process and get even a little bit more stable? Um, I think that everybody, honestly, except for people that have such extreme instability, doc, I think they should start with doing a little bit of tendon dry needling, because it's so easy to do and it's much less risky. And now, please don't misconstrue that. I don't want anybody to go find an acupuncture needle and just try to start doing it on your own. It's not easy to do, but relative to some of these high level procedures that doctors are doing, putting you to sleep, going through your mouth, targeting the alar and transverse. I mean, that's really high level and difficult and invasive and has to be done super careful. Or going posteriorly into the C0, C1 capsule. I mean, that's pretty, high level real estate where you've got things to avoid on many of the different sides.
Yeah.
I would say C1, C2, people are starting to acknowledge that it's not as hard as they previously thought. You can kind of pretty quickly with ultrasound, you can find out where the vertebral artery is, and you can get into that. It shouldn't be seen as hard as it is by many of these brilliant and incredible hand-eye coordinated physiatrists and medical doctors that do physical medicine and rehabilitation. I think we'll see in the next several years more and more doctors that are taking that on, and
Yeah.
not as they see how important it is for people. At this time, you still have to go to one of the clinics that has been doing it again and again and again and just has good results and continues to work on it. But if you contact the tendons that connect onto the C2 spinous process and then connect back up to the skull, those are very, if you go to a skilled person, very, not super invasive to work on. And you may find that you start feeling a lot more stable just from getting those muscles back online from stimulating the tendons.
So tell me, is there a difference? I mean, I've heard the term dry needling a lot, but I've not heard the term tendon dry needling per se. Are those different or are they the same thing, but I'm just hearing a new word?
Yeah, I guess it is. I'm going to say it's very different. Okay. So when I took dry needling, we learned how to stimulate a tendon or an enthesis, a connection point of a muscle onto the bone. But it was probably overlooked as far as I think how valuable that it is in these difficult cases. And really, tendinopathy or a tendon problem is 30% of all musculoskeletal diagnoses for people that go in to see their doctor nationwide. 30% of the time, they have some strain sprain, some tendinopathy, tendonitis, something along those lines. So it's a very common thing that's happening that nobody really has historically, I feel, addressed correctly. If you look on the literature, oh, well, we don't know if we can fully ever heal tendons. And I haven't done a lot of pre and post MRI, and I'm going to probably start doing more studies where I get really good ultrasound images of tendons in the beginning and work on them several times and then repeat it because it'd be good to see. But the people are getting the results. I mean, and
Now, is this
so
mainly because you're focusing on the suboccipital muscle group and as a specifically? Because I don't hear
well,
a lot of people telling me that they have practitioners, whether through IMS, dry needling, address that region. It's usually traps, levator,
yeah.
the larger group muscles, but not so much when, talking about C2 spinous.
So it could also be lower. So we know we have splenius cervicis connects from the upper back to the neck,
Yeah,
capitis from the lower neck, upper back to the skull. You've got levator, C1 to C4. You have, the SCM, which connects from the mastoid. That's a really good one to work down to the sternum and the clavicle. There's a lot of, you have omohyoid, which, sometimes the scapula connection actually
yeah,
can be pulling and tugging on the neck and
yeah.
creating issues. The multifidi, you have, the rotators. So there's a lot of different tendons to think about and consider as to where you're going to get the most value early on. Because sometimes people, that they're in this position and they're eventually going to need to get their suboccipitals worked. But if you only treat the suboccipitals, or if you only treat C1 ligamentously, but you don't first get them in a position where they can hold their head here, it's like taking a vitamin when your stomach can't absorb. It doesn't make any sense to me why people, I guess you're getting a little bit of benefit. You might absorb 5% of it, 10% of it, but hierarchically, whatever the word would be, you're going to want to first get your digestion on board before you take $100 special supplement. You're
Yeah.
going to first want to get yourself to be able to hold yourself in a reasonable posture before you're going to want to get that $10,000 injection to the C1 ligament. Because otherwise, if the reason that it gets bad is because there's an excessive force of a 10-pound head on a 2-ounce bone, and you're trying to get it better while it's in this position, it just seems it doesn't make sense to me. Maybe my brain works weird, but it seems a little bit crazy to me.